Bismillahirrahmanirrahim. I'd like to thank the chairpersons and all the audience. This case is an uncommon presentation of chronic kidney disease, mineral and bone disease. This case was picked up from Kingdom, Saudi Arabia. A 27-year-old Yemeni male with end-stage renal disease, secondary to chronic glomerulonephritis, started hemodialysis in January 2022 in a local charity hemodialysis center for 3 years. Then continued his dialysis schedule in King Abdulaziz Hospital in Mecca, Saudi Arabia. On presentation, he was a wheelchair-bound patient complaining of painful masses at the right side, both hands and shoulders, which started 1 year ago with progressive enlargement and tenderness. On examination, the patient was feeling unwell, malnourished, with history of recurrent hemodialysis access failure. Vital signs were stable. He had multiple hard and tender swellings over the lateral aspect of the right side, measuring about 20 by 20 centimeters, at the anterior superior aspect of the right shoulder, measuring about 15 by 15 centimeters. The left acromioclavicular joint was also involved with two small masses sized about 3 by 3 centimeters with restricted mobility of the affected areas. No joint effusion or neurological deficit were found. Also, he had multiple enlarged nodules over both hands, especially around the wrist. They were non-tender and clinically resembled gouty to 5. Cardiovascular, pulmonary, and abdominal examination were unremarkable. This photo shows the multiple swelling over the right and left shoulders, and those are the nodules on the hand. Patient's X-ray showed extensive diffuse soft tissue calcifications at the right hip, right and left shoulders, and both hands, obliterating the joint spaces. The X-ray shows extensive calcification over the right shoulder and right hip joints as a sequel of poor dialysis. This radiograph showing soft tissue calcification around the rest of the patient. Laboratory investigation on presentation. The patient had a blood urea of 43.13, serum creatinine of 5.48, serum calcium of 10.8, serum phosphorus of 7.6, calcium phosphorus product was 82, intact parathyroid hormone was 1616 picogram per milliliter. Alkaline phosphatase level was 368, albumin was 3.7. The patient had a positive hepatitis B surface antigen. The KT/V of the patient was 0.7. Parathyroid scan showed diffuse parathyroid hyperplasia. The patient was on medications in the form of amlodipine 10 mg per day, alpha-calcidone 0.25 microgram per day, calcium carbonate 500 mg caps, two capsules 3 times daily during the meal as phosphate binder, in addition to a daily multivitamin. Fine needle aspiration of the hand nodules and the right hip lumps yielded thick, milky white material, which under the microscope demonstrated calcified cavities and regions of fibrous tissue with numerous inflammatory cells. A papillary-like structure or papillary structures with multi-nucleated giant cells and foamy histiocytes surrounded by calcified granules. Echocardiography showed left ventricular hypertrophy, normal global left ventricular function with ejection fraction of around 60%, calcified posterior mitral valve leaflet and mitral annulus, calcification in the anterior aortic castle, with no pericardial effusion. The patient started treatment as follows, with low phosphate diet, about 1 gram per day, and intensive hemodialysis in the form of about 4 sessions a week for 6 months. Each session was of 4 hours with a blood flow of 300 to 350 milliliter per minute, using a low flux dialyzer of a surface area of 1.7 millimeter square approaching a KT/V of 1.2 to 1.34. Calcium carbonate and alpha-calcidol were stopped. Calcium-free phosphate binders, sevelamer hydrochloride, 800 micromilligram 3 times per day was started. Then replaced again with calcium carbonate, as serum calcium and phosphorus levels became normal after 3 months. As parathyroid hormone was still high, we started pulse oral alpha-calcidol 3 microgram 3 times a week per oral for 3 months. Our patient showed good clinical response in the form of increasing weight, improving movements of the joints, and marked reduction of the swelling size. With the following results were obtained 10 months after his presentation. Serum calcium of 8.9 mg per deciliter, phosphorus of 4.2, calcium phosphorus product was 37.4. Magnesium was normal with intact parathyroid hormone of 465 picogram per ml. Those are the KUK guidelines for stage 5 CKD. We target parathyroid hormone between 150 and 300, serum calcium between 8.4 to 9.5, and phosphorus between 3.5 to 5.5. With keeping or trying to keep calcium phosphorus product less than 55. This picture shows a marked resolution of the soft tissue calcification after treatment. Parathyroid scan, the repeated parathyroid scan showed no more significant abnormalities and were reported as negative study. So what is the diagnosis? Is it leiomyoma, leiomyosarcoma, tumoral carcinosis, or gouty tophus? Tumoral carcinosis, right. Surgical removal of soft tissue calcification is the treatment of choice. True or false? Regarding KUK goals for stage 5 CKD, all the following are correct except serum parathyroid hormone between 150 and 300, serum calcium between 8.4 and 9.5, serum phosphorus between 3.5 and 5.5, or calcium phosphorus product more than 55. The last one. Among the following phosphate binder, which agent can reduce LDL cholesterol? Management of hyperphosphatemia in CKD patients include dietary phosphate restoration, dialysis, phosphate binders, all of the above or none of the above? Yes. Regarding calcimimetics, all the following are correct except they decrease the sensitivity of the calcium sensing receptors in the parathyroid glands. They are used in a dose of 30 to 180 milligrams per day. They reduce parathyroid hormone, calcium, and phosphorus. They are less likely to have parathyroidectomy and less likely to have fractures. Yes, that's right. Number 1. Therapeutic options for secondary hyperparathyroidism. New phosphate binders offer options for phosphorus reduction without increasing serum calcium. True or false? True. Vitamin D analogs lower parathyroid hormone and increase bone mineralization, but also raise calcium and phosphorus. Acinic acid can be used to lower parathyroid hormone despite elevation in calcium and or phosphorus. Intensive dialysis has no role in managing mineral and bone disease in end-stage renal disease. Parathyroidectomy can be useful for lowering parathyroid hormone when pharmacological intervention fails. The clinical presentation and histological findings were characteristic of tumoral calcinosis. This case illustrates a rare differential diagnosis of a subcutaneous nodule or tumor-like lesion in a patient with end-stage renal disease. It can mimic a soft tissue tumor like a leiomyoma or a leiomyosarcoma, or it may be confused with a gouty tophus, which is not uncommon in patients with impaired renal function. Vigorous control of the secondary hyperparathyroidism and increasing dialysis remain the mainstay of treatment. A high level of suspicion of this rare entity and a correct diagnosis can avoid unnecessary surgical intervention. Soft tissue calcification in renal failure has been recognized since 1901. The exact instance of soft tissue calcification in patients with renal failure is unknown, since the detection of visceral calcification is difficult during the patient's life. The combination of marked hyperphosphatemia and normal or low normal serum calcium concentration results in an elevated calcium phosphorus product, which is associated with increased mortality. When the calcium phosphate product is high, due in part to the increased intake of calcium via using the calcium-based phosphate binder, there is a tendency for calcium phosphate to precipitate in arteries, joints, and soft tissues and the viscera. This process is called metastatic calcification, or when very severe and leading to tissue ischemia by affecting the normal arterioles called calcifications. Soft tissue calcification involves most frequently kidneys, lung, stomach, arteries, and the heart. It starts before end-stage renal disease and increases during the progression of CKD. Although there is a myriad of factors that contribute to metastatic calcification, including high parathyroid hormone, calcitriol treatment, local tissue pH, high calcium and phosphate product, and magnesium deficiency, calcium and phosphate overload are perhaps the major factors leading to soft tissue calcification in renal failure. Take-home message: intensive hemodialysis can be another modality to treat soft tissue calcifications in end-stage renal disease. In our patient, we use calcium-free phosphate binder, pulse or alpha-calcidone, but we think that the major role was related to the intensive hemodialysis. Thank you very much.
شغل العرض الشرق ده لكن اللي هي تحفظ على او كومنت. طبعا هي الحاله متاخده من السعوديه. طبعا الدارس مش ده مش الانتنسيف دارس اللي اتعمل، اللي كان بيتعمل قبل كده اندر دارس، فده موديل للاندر دارس والسيكونس بتاع البيل. فانا خلي بالنا من الكلام ده. يعني اعتقد كده على دي كانت 7 من 10 ولون ستاندنج اندر دارس ونجلكتد، وبعدين اللي اتعمل على ما يبدو الدكتور سعيد اكتشف بقى في الانستتيوشن ده فحسن الدياليسيس، فده اللي جاب نتيجه معاه. لكن العرض يعني ممتاز، برزنتيشن ممتاز.
انت كنت قلت ان العيان ويل شير باوند، مش كده؟ ده ايه اللي حصل له بعد كده؟ ده يمشي؟
خدنا ان الموفمنت امبروفد.
طب حلو، كويس قوي. طيب الحاجه الثانيه، do you think cinacalcet is a first line of treatment?
In this patient, unfortunately, it wasn't commonly used at this time.
Was he fit for surgery?
For surgery, for secondary hyperparathyroidism?
Yes. Not because I'm a surgeon. The cost of cinacalcet is too much compared to surgery.
Yeah. We didn't use cinacalcet.
Cinacalcet?
No. It wasn't widely used at this time. I'm just telling that. We didn't mention cinacalcet in the treatment. No.
2002.
Oh, a long time ago.
We didn't use it.
Thank you.
Okay.
Did you publish this case?
No.
Because it's a very interesting and nice demonstration of how regression can take place in metastatic calcification. You should publish it because it's really nice.
Thank you.